Good morning, everyone. Thank you so much for coming, and thank you to Tina Berger for the kind invitation. I am very honored to work with Dr. Lori Chung at Stanford University for the Scleroderma Center, and we collaborate closely on a lot of different clinical trials. So I'm really excited to talk to you today about what's been going on, what's the latest in the field. I think it's an exciting, promising time in terms of scleroderma. I think we are learning more and more about pathogenesis. We're learning more and more about how we can really make inroads in this disease. I want to start with disclosures. So I do get some research funding from Sanofi. I've consulted for Genentech and Sonoma Biotherapeutics, unrestricted gift from Beyond Meat. That is not relevant to this talk. And then I'll just tell you by way of background, I actually spent 5 years at Genentech. So I have clinical development experience. So I have a little bit of an insider view. I hope I'm not too biased, but I think that it's really helpful to kind of have the perspective of what it takes to develop drugs and how we bring them to patients. So with that, let's jump in. So here's what I'd like to talk about this morning. I'd like to give a very brief review of systemic sclerosis. I think you guys are all more expert than I am, but I'll give you my view. And then talk a little bit about pathogenesis. I think this is a complicated area, but I do think there's, like I said, a lot of exciting progress in terms of our understanding. Then we're going to run through some clinical trials, focusing on the ones that we've been doing at Stanford. And what I'd like to end with is sort of setting up the context for my dear colleagues, Dr. Sally Arai, who's in the back, and Dr. Everett Meyer, who I've been very closely collaborating with on cell-based therapies. So I think that there's a lot of promise. And so I just want to kind of set the stage, and then they will tell you more about that later this morning and afternoon. And then we'll end with some discussion. Okay, so Scleroderma 101, very basic. I think this is something everybody knows. Very roughly, we divide scleroderma, also called systemic sclerosis, based on skin involvement. We have let me see if my pointer works, the limited cutaneous and the diffuse cutaneous subsets. The limited is about 65%, the diffuse is 35%. And as you can see, limited really does have limited involvement, basically from the elbows forward, distal, or from the knees down. It can also involve the face. Often limited scleroderma will just involve the hands, even just the fingers. And sometimes it's really even hard to tell that there's any involvement. Diffuse, on the other hand, is a much more, is much more extensive involvement of the skin, can be more rapid in progression in terms of its onset, and can be more associated with, organ manifestations. We'll talk about both of them. So that's just the really rough overview. Here are some pictures from Dinesh Khanna and Chris Denton from The Lancet, where they showed examples of diffuse cutaneous scleroderma, where you can appreciate, often the face is a little bit, you can tell the face is a little, stretched. No need for Botox here, right? No wrinkles. That's a perk. And then sometimes even the oral aperture can become smaller, due to kind of subcutaneous fibrosis. People can have extensive skin thickening and even subcutaneous thickening and fibrosis, leading to contractures, leading to disability, mobility issues, which is very, very frustrating. And you can appreciate kind of some of the changes in the skin, various changes, sometimes hyperpigmentation or hypo. A lot of times we'll see salt and pepper, pigmentary changes. A lot of patients may have pruritus, meaning itchiness, when they have skin disease activity. I always ask about that. And of course, what's not shown here are examples where people can end up getting digital ulcers, where they have impaired vascular flow, so leading to more injury and ulcerations of the fingers most commonly. Whereas in contrast, let me show you a picture from limited cutaneous. So really, you can still have facial involvement, but often this is spared. And then you can, typically it's the hands that are involved most commonly, but it can be more subtle. Typically it starts as puffiness, and then over time it can become a little bit more bound down, tight, fibrotic. And one thing that this picture is showing is when people have chronic Raynaud's, essentially, they're getting vascular perfusion issues, and you can end up seeing these dilated capillary loops on their nail beds. And so that's something that we always look for. You can see what are called ragged cuticles. So the cuticles are looking a little bit not so, clean, again, from decreased flow and perfusion to the fingers. One of the most complicated complications that is literally hard, not to make a pun, but it's hard to deal with, is the calcinosis. And so I think this is where we need better treatments. So I know that the research is trying to kind of get at that better. So this is an old graph, but it still holds true, from Ginny Steen and Tom Metzger, where it kind of gives you the overview of, on the x-axis, disease duration, on the y-axis, skin thickness. And so you can appreciate that diffuse disease, as I mentioned, kind of has a very rapid onset and progression. The skin thickening happens early and quickly. You can have a lot of these joint contractures. And then we talked about internal organ involvement. So most commonly the GI, esophageal involvement in 90%, but even lower GI involvement. Lung is something that we're always looking out for, interstitial lung disease, and then heart, kidney involvement can happen. And then over time, the skin may actually start to loosen up. It doesn't go back to normal necessarily, although that is our goal, but this is sort of the natural history of what the skin does. In contrast with limited, you can appreciate that the skin kind of starts to get thick early, and often, again, this is just typically just the hands, and then it kind of sort of stays pretty stable, not a lot of change, but you can end up having later manifestations. So we're always screening. My poor patients, I make them go do echocardiograms every year and pulmonary function tests just to make sure that there's nothing, that's no complications that are developing. So there are later internal organ issues that can happen with limited. This is a little bit of the alphabet soup. I want to thank Lori Chung, who lent me some of her slides. But this is a complicated schematic that shows the different manifestations of scleroderma. And a lot of these tend to correlate with the autoantibodies. So, as Tina was talking about misdiagnosis, I think that that's true. A lot of people say, oh, I have a positive ANA, I have lupus. And that's such a common story, right? Everyone says, oh, I have lupus. And it turns out, well, there's more to the story than that. And if you dig a little bit deeper, you'll find there are these more specific autoantibodies that can be correlated with scleroderma. And so SCL70 is probably the one people know about, scleroderma 70. Centromere is the other common one, and then RNA polymerase 3. These are the three scleroderma-specific autoantibodies that have slightly different flavors, I will say. SCL70 can be more associated with interstitial lung disease. RNA polymerase 3 is more associated with something called scleroderma renal crisis. And then centromere antibodies are more associated with pulmonary hypertension in a minority. So like only about maybe 10, 15% will develop PAH. And then there's a whole host of other autoantibodies that we can see. There's one called PMSCL, which stands for polymyositis scleroderma. These are people that tend to get like an overlap of both muscle involvement as well as scleroderma. I have several patients that have overlaps, and so that's something that is worth being aware of. So bottom line is we have to really, it is worth, going to a scleroderma expert to truly, because we see a lot of these patients and understand kind of the subtle manifestations. This is not just lupus, so keeping that in mind. Okay, we're going to go back to basic 101. This is actually a very, very high-level schematic. This was actually a review that we published back in 2011, and it still holds true. So the high level is that scleroderma pathogenesis really is a complex interaction between genetics as well as environment. I think we've learned a lot. We're still learning about genetics, but I'm also very much interested in what are the environmental factors that may set us up for scleroderma. But whatever happens, whatever these factors are, we know that often it starts with Raynaud's. I think many of you have dealt with the, Raynaud's, fingers turning white, fingers turning, blue or red. So there's clear vascular abnormalities that underlie a lot of scleroderma pathogenesis. And then that may lead to also the immune abnormalities that we see. Autoimmunity, the ANA, a lot of these other autoantibody and T cell driven manifestations, as well as B cells. And then that somehow, between the vascular and the immune abnormalities, this leads to fibrosis. And these are very complex pathways we're going to be talking about a little bit more. So it's an interplay of these three different domains. Okay, now we're getting a little more detailed. So we talked about starting with vasculopathy. With the vasculopathy that develops with scleroderma, you can end up having, endothelial cell apoptosis, meaning death, and that can lead to release of things, that can lead to stimulation of the immune system, which is thought to then, again, this is thought to interact and drive the immune milieu that may set things up for fibrosis. And in addition, the vasculopathy may also lead to fibroblast activation that further drives fibrosis. And I think we're starting to really understand a lot of the players that are mediating these different steps in the cascade of scleroderma. So here's an even busier slide. Sorry, and I know it's too small, but let me just sort of highlight a couple things. So this represents the B cell activation side of scleroderma. And B cells can differentiate into these cells called plasma cells, which then can crank out a bunch of antibodies. And these are super important when we have an infection. We want to clear the infections. Vaccines will induce an immune response, including antibodies. But the problem is in autoimmunity, these can end up being autoantibodies, and they can stir up trouble. And so this is an important aspect that we are able to target either by depleting B cells, or actually now there are going to be cell-based therapies that can deplete B cells. And we'll talk about, Dr. Sally will talk about auto BMT, but Dr. Everett Meyer will be talking about some of the CAR T cell therapies that are capable of depleting B cells. Here is the arm that talks about kind of the T cell based approach, and as well as monocytes and macrophages. There's an innate immune response as well as an adaptive response. There's drugs like, so mycophenolate is probably one of the most commonly used drugs that we have in our arsenal. Tocilizumab is an IL-6 inhibitor that has become more and more commonly used, that helps kind of, again, with this macrophage axis of activation. And then finally, this bottom aspect represents a lot of the mediators that are thought to be driving fibrosis. And this has been a little bit of the holy grail for scleroderma. I feel like back when I was at UCSF for many years, and there wasn't a lot available for fibrosis. And I think what's super exciting is now there's a lot of trials that we'll talk about today that are starting to target this aspect of scleroderma. I guess I'll highlight a few. I think, people are familiar with nintedanib and pirfenidone. These are some of the drugs that are used for IPF that are now being used for scleroderma. But there's other mechanisms we'll talk about shortly. So I think the question is, how do we do this? Do we target one arm, two arms, all three? Do we need a very holistic approach? I think that remains to be seen. But I do think combinatorial approaches are helpful for this disease because, like I said, there's three distinct domains that we have to be thinking about. Okay, so given that background, let's jump in. So I'm excited to share with you one of the trials that Dr. Chung and her team are doing at Stanford called the Conquest trial. This is sponsored by the Scleroderma Research Foundation. Very grateful to them for putting this together. And I'm going to mess up the names of these drugs, but amlitelimab is an OX40 ligand antagonist, and nerandomilast is a PDE4B inhibitor. So we're going to talk about a little bit of the background. The coolest thing about this is that this is set up as a platform clinical trial. I don't know, does anyone know what a platform clinical trial is? So this is, someone in drug development, you get it. Okay. So this has kind of been a really exciting, this is called an adaptive clinical trial. And what's really cool is that you can basically test multiple therapies. You have a common set of patients that can get randomized to different arms, standard of care, intervention 1, intervention 2. You then can do an interim analysis, decide, this intervention 1 didn't work well, you can drop it. You can add an arm, intervention 3, bring that on in. And then you can literally rejigger things and ultimately at the end of the pipeline, come out the winners. So it's really exciting to have this adaptive flexibility because it also allows for just speedier development. So let's talk about this. So the Scleroderma Research Foundation, led by Luke Evenin and colleagues, has really been pivotal in this. And basically, what he did was create a collaboration with several different biopharmaceutical companies, the idea being to accelerate the development of potential treatments. Very exciting. I give him a lot of credit for this. So what he's done is created more than 150 scleroderma centers of excellence in over 30 countries that have signed on to this platform, which is super exciting. Again, unprecedented for scleroderma. And of course, he's reaching out to all these different companies to try to find the best potential, players, potential therapies that are worth testing. So this started recruitment in April of 2024. So this is hot off the press, very exciting. And one of the key advantages I'll mention is that you can share placebos across multiple therapies. So one of the things that people don't like is, oh gosh, what if I get randomized to placebo? That's not helpful. A lot of studies get around that saying, well, we'll guarantee you'll get drug at the end in an open label extension. But of course, a lot of times it's not nice to be like, oh, 1-to-1 randomization, I have a 50% chance of getting placebo. So having this type of setup allows, they can actually reduce the ratio of placebo and more active. It's so awesome. One of the issues with individual company trials is they take a lot of time. And believe me, when I was at Genentech, I remember you're trying to find the right centers. You're trying to kind of get the centers up and activated. You want to make sure they're doing quality, choosing the right patients, getting the right measures, and all these other things. The fact that they've pre-vetted 150 centers, this is unprecedented. So super exciting, more than 30 countries, right? These are global. And I think that really guarantees also kind of the quality of these trials. Because garbage in, garbage out, we don't want that, right? So, and then it allows a seamless transition to phase 3. So I want to celebrate Conquest because this is a big accomplishment. I have to credit Luke Evnan and the group there that have been leading this. And so here's the schematic from Conquest. So their idea is they now have 2 different trials. They want to have basically people that are similar entry criteria. They can randomize to therapy 1 versus therapy 2, and then active placebo. They can have more on active than placebo. And you can appreciate that placebo gets shared across these arms, which is really a huge advantage. For this particular trial, they're targeting 400 people, so they're going big. Okay, so let's talk about the 2 drugs they're looking at. Amlitelimab, OX40 ligand. This is, so let me tell you a little bit about co-stimulatory pathways. Many of you may be familiar with checkpoint inhibitors and immuno-oncology. So immunotherapy is based on the premise that for T cells to be activated, you don't need just a T cell receptor signal, you need a co-stimulatory signal. So what oncology trials are doing is they're actually they're blocking the co-inhibitory signal so that the T cells get more activated. This is the opposite. This is where they're blocking a co-stimulatory signal so that the T cell gets dampened. So it's kind of turning the volume down on the T cells. And so OX40 ligand, let's try that again, right here. So it's basically the activated T cell has an OX40 receptor, and then the antigen presenting cell has the OX40 ligand. And they're blocking this interaction to prevent the T cell from getting activated, because when it does, look at all the downstream, interactions that this also can affect. So you can also block the B cells and the NK and the activated CD4 cells. The endothelial cell has OX40 ligand, as well as mast cells. So it's pretty exciting. I think this holds a lot of promise in a lot of diseases. The goal is it aims to restore the balance between pro-inflammatory and regulatory T cells. I'm going to show you some data for atopic dermatitis, but it's currently being developed for atopic derm, for asthma, for hidradenitis suppurativa, and then they said they're going to be initiating studies in 2024 for scleroderma, celiac, and alopecia. So let me show you some of the early data. So this is the phase 2b study from mild to moderate atopic dermatitis. And what I'm going to tell you about skin disease is that atopic dermatitis is a disease where you need pristine safety, because atopic dermatitis doesn't kill you. And so the FDA will not allow you to have a lot of safety signals to develop your drug. And so I tell you that because whenever I'm thinking about drugs, I'm always focused on safety first and then efficacy second. And it's got to be that order. If it's not safe, I just don't want, and obviously your safety tolerance is different, right? Based on how bad is it. If it's cancer, that's a different story. But the point I'm making here is this is atopic dermatitis. They got a whopping good signal in terms of efficacy when they looked at, this is their 250 milligram with loading dose. They looked at kind of They did a very strict analysis here, and then the black bar represents, people that might have had other like all-comer analysis. But you can appreciate there was a big efficacy signal based on the eczema area and severity index. And importantly, what I want to show you is the safety. And so when they looked at, they had 310 people that got treated, and placebo was 78. So this was a big trial. And you can appreciate any treatment emergent adverse events. So, 60, 67%. But the good news is very few of them were any serious adverse events, so 2.6%. Adverse events of special interest, so about the same across the different groups. And then any treatment emergent adverse event requiring discontinuation, it was actually less in the drug arm, which I think is really interesting. And they almost all of them, 94% of them were mild or moderate AEs. So I think this is incredibly promising. So I want to just share that with you. Okay, then let's talk about the second drug. So Conquest is doing a second trial, they're randomizing into the first drug I mentioned, and then this drug, which is basically, let me say it, nerandomilast. This is a PDE4B inhibitor. And so what I'm going to show you again, what's exciting is that this trial just got published in the New England Journal of Medicine for IPF. And as we know, IPF, clearly very relevant to scleroderma, lung fibrosis. And so, this drug, PDE4 inhibitor, has anti-inflammatory and anti-fibrotic properties. So they just finished this phase 2 randomized trial in IPF, 147 patients. Their primary endpoint was FVC, forced vital capacity at 12 weeks. It's interesting. They actually randomized, they actually stratified based on use of background antifibrotics or not. And so they allowed it or didn't, because sometimes that can mess with your results. And they basically saw no difference in terms of the safety events between the treatment group and the placebo group. So I think very reassuring. So here's the data. So here's the FVC at 12 weeks, and you can appreciate that the people that were on treatment had a significant decline, had a significant improvement in their FVC, I should say this, I misspoke. The people that were not on treatment, placebo, had a decline in their FVC. The people that were on treatment really didn't change that much, and that's depicted here. The idea is you want to maintain forced vital capacity when you're on drug and maintain lung function. And you can see the placebo group, even over a short 12 weeks, had a decline. So pretty striking results. And so based on this data, they received an FDA breakthrough designation, which is a vote of confidence. They're now moving into phase 3. This is called the FibroNear IPF trial, 1,177 patients with IPF across more than 30 countries. So they're going big. 3 groups randomized into 9, 18 mg or placebo twice daily. And they're going to go for a primary endpoint of change in FVC over weeks to week 52. And basically they did their top line readout, and their trial met its primary endpoint. I literally just looked this up. It's all hot off the press. They're going to be releasing the detailed data early in 2025. So I hope it's going to look really good. So let's keep our eyes and ears peeled on this, but I think this is very promising, and with a good safety profile, I think this looks really good. So given that, let's talk about Conquest. This is the platform trial. They're looking for diffuse or limited, modified Rodnan skin score between 10 and 35. Onset of scleroderma needs to be less than or equal to 5 years. Presence of ILD, so that's really the key component here, with evidence of fibrosis. And then, of course, as with all trials, there's drug stability requirements. And so you can read here, you have to have been on it for at least 6 months, no dose adjustments in the last 3 months prior to getting on, hydroxychloroquine, stable in 1 month, and then steroids not greater than 10 milligrams. Exclusion, so if you don't have any pulmonary abnormalities that are consistent with ILD, that's important. Unfortunately, if you have a history of a stem cell or bone marrow transplant or CAR T therapy or solid organ transplant, you're excluded. No smoking. And no active or suspected malignancy, history of malignancy within 5 years, except for some of the skin cancers and in situ cervical cancer. No cell depleting therapies other than Rituxan, and there are some washout periods that are listed here. Okay, so that was very exciting. Let's talk about the Athena study. This one is currently recruiting at Stanford, and I'm going to butcher the name again. This is a tulisokibart. Tulisokibart? I don't know. This is Prometheus, and they got bought by Merck not too long ago. So this is a TL1A inhibitor. This is a member of the of the TNF family, and just high level, I'm going to show you that the TL1A is a cytokine that's made by a bunch of different cells, and then it can act on these are the innate lymphoid cells, naive T cells, NK cells, and you can appreciate what we call it has pleiotropic effects. It has multiple different effects, modulating a bunch of different cytokines, many of which are thought to be relevant for scleroderma. Let me show you why they're moving forward. This is a very busy slide, but basically this was a study that was done. I don't know if anyone knows Carol Fagali-Bostwick. I have a lot of respect for her. She's an amazing woman, amazing scientist. Here's the data. They took mice. They did the bleomycin lung fibrosis mouse model. Here is the control, and then DR3 is actually the receptor for TL1A. And what you can appreciate is after bleomycin, you get a bunch of fibrosis. Trichrome blue staining is for collagen, and that is depicted by these little triangles here. There's a bunch of fibrosis that occurs, and you can appreciate by giving an antibody that blocks TL1A signaling, it totally goes back down to the controlled normal. So this is a pretty striking result. Another way they look at it is alpha smooth muscle actin in the red. This is what myofibroblasts express. So that's fibroblasts turn into these more active myofibroblasts. And so here's the control, or the bleomycin instilled. There's a lot of lung fibrosis, and it literally went away when they treated with this antibody. So pretty exciting. Again, this is mouse data, but important to get sort of the proof of concept there. So what I'm going to show you is where is this drug in development? It is actually gone through a phase 2 trial in ulcerative colitis. Again, how similar is ulcerative colitis? But I think, again, there's a lot of different pathways that this drug affects. So, and they saw clinical remission at 12 weeks. The effect size was quite good. They did a biomarker trial, which we don't need to go into the details, but they saw similar effect size. But importantly, let's focus on the safety. So the safety really looked good. There was 1 treatment-related adverse event versus 4 in the active group. And serious adverse events, believe it or not, there were more, 7 in the placebo group. And there was only 1 in the treatment group. I think that's interesting. And then 3 adverse events led to discontinuation in the placebo group and 1 in the treatment group. So again, it's looking like the placebo didn't do as well. Maybe that means it's controlling the ulcerative colitis better. So I think the safety so far looks good. The numbers are, again, just under 200. So there's some data here, but I think it looks promising. So keeping that in mind, here's the information on clinicaltrials.gov. They started enrollment. They said they started in 2022. They're hoping to kind of complete enrollment by next year. So we are one of the active sites for this, and they're looking to enroll about 152 people. Here's the information off clinical trials. Again, diagnosis less than or equal to 5 years, diffuse cutaneous scleroderma. They want ILD. They want FVC greater than 45%, DLCO greater than or equal to 45%, and then stable dosing requirements for various different drugs. It looks like they're allowing nintedanib, Ofev, mycophenolate, methotrexate, AZA, or corticosteroids. So that's the high level. And then exclusion, if you've got airway obstruction or significant pulmonary arterial hypertension, if you have another active inflammatory connective tissue disease or any active infections, no smoking. I tell all my patients, no smoking. And then any concomitant medical conditions that are considered unacceptable. And then there's laboratory criteria as well. Okay, here's another drug I cannot pronounce. This is the Horizon study. Oh my God, should practice. Fipaxalparant. Did that sound good? Fipaxalparant. This is an LPAR1 antagonist. And so really quickly, this is a small molecule allosteric, negative allosteric modulator of LPAR1. It is currently in phase 2 clinical trials for diffuse cutaneous scleroderma and IPF. Unfortunately, this is not actively recruiting. We were a site and they've finished recruiting, so we'll see. But let me just show you real quick. The biology is strong. There is work done by the late Andy Tager, who has done really beautiful work on kind of the mechanisms by which LPAR1 is very relevant in fibrosis. And so just to give you the high level, this is a G protein coupled receptor that is downstream of a protein called autotaxin. And then LPAR1 activation can lead to a lot of skin-related fibrosis, lung fibrosis, and vascular issues and collagen deposition. So the idea is by blocking this specifically, they can mitigate a lot of these impacts on skin and lung. So we'll wait to see what those results look like. Hopefully that will move forward. And here's the high level from clinicaltrials.gov. They completed, I want to say, okay, so I think they've finished enrolling their last patient, and so they're hoping then that person's gonna make it out to their 52 weeks. I think we're aiming for about 300 patients, so it's a pretty robust study. We'll see how that goes. Okay, this one doesn't have a name yet. It's a TGF-beta3 inhibitor, and this is by Genentech Roche. And disclosure is that I'm actually involved in this study, so excited about it. I think one thing that's been really interesting about scleroderma is, or about fibrosis in general, is people recognize TGF-beta is thought to be one of the master regulators of fibrosis. And this has long been appreciated, but there's been a lot of skepticism about inhibiting it because the thought is it's too toxic. There have been prior trials where they've gone in and used a pan-TGF-beta inhibitor. And they, again, there's not official data, but they've thought they've seen, anti-fibrotic effects, but unfortunately side effects were limiting. And so I think that was a huge issue. You can appreciate that TGF-beta it's important for T regulatory cells. So you can imagine if you inhibit that, you may end up getting a more robust autoimmune response. It inhibits other innate immune cells. But importantly, it is a really fundamental regulator of fibrosis, even cardiac fibrosis as well, endothelium activation. So what I want to point out is that there's actually 3 different TGF-beta isoforms, 1, 2, and 3. And no one has really done a super deep dive on how different these 3 isoforms are. I think that, TGF-beta 2 may have some roles in development. TGF-beta 1 has been probably the most studied, but TGF-beta 3, I think, is something that, was not well appreciated. And so along comes Genentech, and what they ended up doing, and I know a little bit of the backstory here. Do you guys remember the Actemra trials? They did these trials for the IL-6 inhibitor. They had all of that data, and they were able to go through it and look at the skin biopsies and the biomarker data. And what they found is that there's a very, very elevated TGF-beta signature in the skin in the patients with active scleroderma. And I'm going to blow this up for you. So what they found is that in the skin, correlating with this TGF-beta signature was TGF-beta 3 expression. So TGF-beta 3, which has really been underappreciated, they found that TGF-beta 3 was the most correlated with the skin biomarker signature. And they looked at serum biomarkers that also correlated. And then they looked at the modified Rodnan skin score. So the degree of skin fibrosis was correlated with TGF-beta, and they found, again, that TGF-beta 3 seemed to be a really important player. And so because of that, they basically found all these correlations, and they went on to develop a very potent and selective anti-TGF-beta 3 monoclonal antibody. So this will not hit TGF-beta 1 or 2. And I think TGF-beta 1 is thought to have a lot of the sort of signals in terms of safety signals. So their idea moving forward is that this is going to be a safer way of getting at fibrosis. And so we are now in the trial. Unfortunately, it's closed to enrollment, but we're going to wait and see. We've got a couple patients on study. There was a multiple ascending dose stage of a 12-week treatment period period, followed by an open label safety extension going out to a year. And they're anticipating that they're going to take their top line cut of data coming up soon, hopefully. So we're really looking forward to those results to see what that shows. So stay tuned, hopefully more soon. Okay, I'm going to end with B cells. I think there's a lot of excitement about this. So let me go through. So we talked about that, right? This is Rituxan, and there's Benlysta, and there's other B cell depleting agents that are available. But we're going to talk about setting the stage for cell-based therapy. I'm going to go back to some work that actually I was involved in when I was at Genentech. So I think many of you are familiar with lupus. There was a lupus nephritis trial called LUNAR that was done over a decade ago, where they looked at a B-cell depleting drug called rituximab, and they randomized patients to Rituxan and placebo. Unfortunately, the study was negative. They did not see improvement with Rituxan. However, this is the one example where doctors out there still use Rituxan a lot because they're like, but it works. And so the question is, was it a study design issue? What was the reason it failed? There's been so many analyses trying to get at this conundrum. So when I was at Genentech, I actually was able to help with an analysis of 68 patients that received Rituxan and had data on the degree of B-cell depletion. So to kind of guide you through this, we split the groups up into, did people get a CD19 B-cell depletion of less than 20 cells, less than 5 cells, or completely zero? And so we basically looked at these 3 different groups. We had this data, and 100% of patients achieved depletion to the level of 20 cells to the level of 5 cells, but only 78%, so 53 patients, achieved this complete peripheral depletion. So let me show you those results. There. Okay. So I'm highlighting for you in red the now it's only 53 patients who achieved complete depletion based on the what I just told you the definitions were, versus the patients who were not completely depleted of B cells. And you can appreciate clearly there's a big difference in terms of efficacy. So the degree of depletion of B cells matters. Why do some patients not deplete as well is another important question. Rituxan, there's now been 2nd generation, 3rd generation B cell depleting antibodies. Obinutuzumab is one that is going forward in lupus nephritis. And I won't go through details there, but the question has been, are we not depleting well enough? Is that the problem? I want to point out one important caveat. When we measure peripheral B cells, we're doing on just the blood, we can basically find 0 B cells, but that doesn't mean you don't have depletion completely in your body. You still can have central B cells. So in your lymph nodes, in your spleen, there still are B cells that could be there. And so this is the premise on which maybe a more effective B cell depleter might actually have better efficacy. So let me show you some data. This is the Desires trial published in Lancet Rheumatology 2021. And it was a multi-center double-blind parallel group RCT where they randomized patients to Rituxan, 375 mg per meter squared weekly for 4 weeks compared to placebo. They did a primary endpoint was change of MRSS at 24 weeks, and their secondary endpoint was change in forced vital capacity at 24 weeks. So they were looking at both skin and lung. These were essentially, I'm trying to remember. Yeah, they were modified Rodnan skin of greater than or equal to 10, no steroids more than 10, no antifibrotic agents or other immunosuppressants within 4 weeks. They excluded pulmonary hypertension. They had FVC less than 60 as an exclusion. And if they had received cyclophosphamide in the past 2 years, they were excluded. Let me show you the data. So this was exciting. They looked at the modified Rodnan, their primary endpoint, and you can appreciate that the Rituxan group had a statistically significant decrease in modified Rodnan. The delta I want to point out to you was, I would argue it's about 6. I'm just eyeballing it, right? So about a 6-point decrease overall in modified Rodnan skin score, which is substantial. They met their endpoint. It's effective. For forced vital capacity, the red is the treatment group, and the goal, as we talked about, is to sustain and maintain lung function. The blue is the placebo, and they did decline over 24 weeks, and they achieved statistical significance here. So it looks like it works, but what I want to show you is even more interesting. When they did the subgroup analysis, they basically looked at patients who started out with high levels of CD19 B cells. So they looked at the group that had higher levels of peripheral B cells as well as a higher modified Rodnan skin score. And I'm just going to quickly go back. This delta was about 6 in terms of modified Rodnan. This delta is 17. So it's not trivial. It's a big difference. Whereas they looked at the people who did not have notably high CD19 cells in the periphery, less than 57, and the difference was like 2.7, and it was not significant. So this also speaks to something that's close to my heart, which is we need more personalized medicine, biomarker-driven trials. I see you nodding. Really, the heterogeneity is something that confounds us. When we throw everyone into the same pot, sometimes things don't come out right, even though some people get benefit and others don't, and then ultimately it kind of dilutes the signal. So, but I think this is incredibly promising data, and I think this sets the stage for more effective B-cell depleters. Using cell-based therapy approaches is one option. There are more powerful B-cell depleters that are also out there. So Everett will be talking about this at our next, in the afternoon. But I think stay tuned. I think there's a lot of promise for this mechanism. And so with that, I want to end with some take-home points. I hope that I've convinced you that it's a really exciting time in scleroderma. I think there's a lot of promising therapies on the horizon. There's several that we're testing. We're just one center. There are several others out there. There's a lot of basic scientists that are working on kind of understanding scleroderma pathogenesis. A lot of drug companies are super interested in this. And I think that, we're seeing more and more therapies that target multiple aspects of scleroderma. There's a lot of immune mechanisms, but importantly, I'm excited about the fibrotic, anti-fibrotic mechanisms that are coming to the fore, because this has been, again, uncharted territory until more recently. So I think it's an exciting time. So thank you for being here. Very excited about this collaborative clinical trial landscape. We talked about platform trials. I think this affords a lot of promise and hope for really accelerating clinical development, really helping get therapies to patients faster and more safely with minimal placebo, a lot of that stuff, quality clinical trials. And I have to thank the Scleroderma Research Foundation for pushing that. And then finally, we ended with B-cell depletion. The fact that, cell-based therapies like CAR T cells that are directed against B cells may be a very promising therapy. I think we have yet to, we were going to wait on that, but Dr. Everett Meyer is going to talk a little bit more about that this afternoon. And so with that, I'm going to ask a favor of you guys. So I mentioned earlier, one of my interests is not just on diseases, but understanding environmental impacts of disease. And I've been involved in a collaboration. I'm actually I'm one of the co-chairs for the aCyr Climate Change Task Force. So I feel like we need to be thinking about our environment, what we're exposed to, chemicals, food, and climate changes. These are all things that are here that we are dealing with. And so I'm going to ask if people are interested, if you can scan the QR code. This is a survey that we've rolled out to really try to understand the patient experience in terms of climate change. Has it impacted you directly? I personally, not to bias you, but I've had patients with lung involvement, and when the wildfires hit, it has caused flares. Examples like that, right? I think we want to understand this better. We want to study it, and so we can then push the envelope, get more funding, and really promote. We're doing this for all autoimmune diseases, so not just scleroderma. But I think this is an important concept that has unfortunately been under the radar, and we need to bring it to the fore. So I want to thank you for doing this if you are willing. All right. And then finally, I want to thank my patients, and including my study patients. And I want to thank my patients have taught me so much. I'm really indebted to them. It's an absolute honor to take care of scleroderma patients. I feel like, I don't know, you guys are like the most gracious people in the world. I'm just like so honored and humbled. I really want to thank Doctors Lori Chung, Dave Fiorentino, good friends of mine, all that they've done for the Stanford Scleroderma Center. They just are incredible colleagues and friends. I want to thank Doctors Everett Meyer, Sally Arai, and the Stanford Cellular Immune Tolerance Program. There's some exciting stuff that that you're going to hear about shortly in this area, and I'm honored to be part of that. I want to thank Tina Berger and the Scleroderma Foundation for hosting this event this morning. I'm going to thank the Scleroderma Research Foundation. I think they've done some tremendous work that is really going to work to accelerate drug development. And again, all of you, I want to thank you for being here today, and let's have some discussion. So thank you.
So first is this on? Can you hear me? First, I will get that slide, and in my recap, I'll make sure everybody gets that slide so they can easily, comfortably scan that QR code.
Thank you.
In my recap. And I also want to say why this was so important today, that we did so much on research, which we don't usually have this much on research, is how far we've come. I've been in this field since 1990. I was a research coordinator at UCLA. I used to have clinical trials that weren't even close to what they are today. And some of you heard me say this last year. I used to go cry in the bathroom and like compose myself working on these clinical trials in scleroderma, and then come back and they just weren't what they are today. And people are here today because of the centers that are doing the clinical trials and the pharmaceuticals. You can go now to your pharmacy and get these life-saving drugs that are on the market. And we're just getting better and better and better in the research and where we are today. So it's exciting that you have brought this, to the forefront. Our patients are so smart, and we make sure that you're educated to make an informed decision. And you all have a list of all the clinical trials that are being done in Southern and Northern California in your list. Every one that she talked about is on your list. So you have the information. What I love is I gave you some information, and she gave you depth into what I have on the piece of paper. So hopefully that will be helpful. So I just wanted to say thank you so much for bringing this to our attention. Thank you.
Thank you.
Any questions from anybody?
No, I believe in the trials. I've done several with you and Dr. Chung. My question is that most of them are set up for less than 5 years or less than 6 years. I am now at the 6-year mark. So as far as future, what does that hold for me? I mean, I'm thinking I'm not going to be able to do very many trials, which is a plus or a minus. But also, I feel like I'm just in a lost point as to what can I do to help myself or to help others that are at this point.
Thank you for bringing that really important point up. And I thank you for your contributions in doing trials. And I was just chatting with one of my trial patients. It really takes a special person, right, to do trials. It's a lot of dedication, a lot of work. And I think, it always breaks my heart because I wish we could include everybody. But I also understand from a drug development side, you don't want to just have this heterogeneous population. You want the early actives. You want to get your signal. The cool thing is I think this landscape is so promising that you can ride on the coattails of those wonderful patients who are in the trials proving the efficacy. Once it gets approved, guess what? Everyone gets access, right? That's the idea. That's the dream, that we really want these to be available to people. Sometimes things get used off label. They're not oh my God, this is getting recorded. Sorry. No, but I'm just saying, I think the goal is you want a drug that's approved, that's safe, most importantly, and then vetted. And then meanwhile, the pipeline for discovery continues. And so, yeah, I always feel bad when you're at that 5-6 year, period where it's like, I'm now excluded. And so I would say, just keep living your best life in terms of, I also, people know I'm very much about like lifestyle-based things as well, really trying to focus on yourself and health and minimizing stress and optimizing nutrition and minimizing environmental exposures. I think this is something I'm starting to also drill down into is just how many toxins are out there, how many chemicals we're exposed to, like just trying to optimize all aspects of your life, which we should all be doing regardless, right? And I think that, and I've seen actually some pretty incredible results of people that have changed their diet or have done things and feel better. Improvement in energy. I swear I had a patient whose skin got better, and I was like, just with diet. So, I think there's a lot of things that could be done. I feel like my goal is to empower you to really pursue those things. try to minimize the stress in your life, really quality sleep, exercise. These are all really good things. I apologize that I can't be here all day because I'm going to be going to an American College of Lifestyle Medicine conference, which I'm super excited about. And I really do believe in these things that, these domains that we can optimize, which really do play into health. So thanks for asking that. Hopefully that answered your question. Mary Lou. Oh, yay. I love it.
What are B cells and T cells?
Oh my gosh. Oh, 101. All right. So T cells are thought to be one of the major drivers of autoimmunity. There are several different flavors of T cells. There's a T helper CD4 cell, there's a T cytotoxic CD8 cell. These are cells that are, and there's I'm looking at our researcher there. There's many other types of T cells we're learning. They are what are called cell-mediated immunity drivers. So they help protect us against so many different infections, a lot of the viral infections, even bacterial. But they're really important, and it's thought that they go awry in the setting of autoimmunity. The B cells, same thing. B cells are important for producing what is called humoral immunity, meaning blood, kind of things that float around in our body, which are the antibodies that are important in mediating a productive immune response against pathogens. I should mention T cells also play an important role in not only surveillance for infections, but also for cancer, as we've learned, and we can modulate those. But unfortunately, T and B cells can get wacky in autoimmune disease. So, targeting T cells, I think, we deplete B cells. It sounds a little crazy. I think back in the day, no one thought this was going to be a good idea, and it was shocking how effective it was for autoimmune disease. But you can't deplete T cells. I don't think. Well, I guess you. And I'm looking at Sally. Sally does some crazy stuff with bone marrow transplant where they deplete everything, and then they. But I think T cells are a little more critical. I think it's a hard thing to just deplete them. But I think actually it'll be really good for Sally to kind of think about addressing that because she's more well poised, because what she does in her practice is she ablates people's bone marrow and then starts from scratch, which is really, I'm always in awe of what she does. We've shared a couple patients where we've done this for Scleroderma and have had some promising results. And so, it's a complicated world of immunology. So thank you for asking. And that's like a lecture I'm not qualified to give.
That's funny.
So thank you.
We have time for one more question if anybody has a question. Okay, we'll go with you after.
I'm just really interested when you're talking about environmental kind of conditions. I come from a different environment, a pretty rural environment that's outside, and I've been very active my entire life. And I'm just curious how you think those things, I mean, we always think of cities, quote unquote, as toxic, but there's also environmental conditions there that you have. But I think just generally a lot of activity and those kind of things seem to continue, make everything better. But I'm just interested in what you think and how you're looking at the environmental thing, not just in one population, maybe.
Thank you so much, Marian. I think, I think the best data is with like silica exposure and scleroderma. These are hard studies to do. I'm just trying to think. I always ask my patients, what do you think started this? And I get a variety of answers. A lot of people don't really know. A lot of times it's an infection. A lot of times it's some stressful event or something that set off the cascade. I mean, the way I'm starting to view disease is I think disease is really accumulation of exposures over time. Right. And then there may be a final straw that breaks the camel's back. You've got the right immune milieu. We're finding people with rheumatoid arthritis have had autoantibodies for years prior to that before they actually get manifestations of joint disease. And I think the same is true here. People with scleroderma, especially limited, they've had years of Raynaud's and then it like breaks open. So these are really tough questions. And I appreciate my smart patients like you who are really good at knowing what they're exposed to and kind of making notes. I think that's the only way we learn. More epi studies are important. But I think, and then this survey, I think it'll be really important to kind of hear your voices.
So I'm not sure if this is in relation to what you're talking about, but I recently found out that I have the MTHFR deficiency. Is that something, I don't know if that's a really long term, but because I've been diagnosed 26 years ago, I can't really do any of these clinical trials. However, are there supplements? I know, like, I can't take a folate supplement to help me out with some of my deficiencies. Like, is there something that can help? Can I get rid of that or increase that MTHFR? I'm not sure if I'm asking the question correctly.
No, you are. It's so interesting. So this is not anything we get taught in medical school. Yet, I think it's really important. I think there are people that have methylation-related defects that are problematic. And so you want to make sure you've got plenty of the methylation support, like the B vitamins, and there's various things like that. I'm not an expert, but I feel like you're asking the right questions. And I think that, this is relevant. I don't know how important I don't know how that plays into the scleroderma piece or not. But yes, we need to be more cognizant of these genetic variants because I think they're important. So thanks for asking. Yeah. Okay. I think I'm.
Thank you very much. Give
Thank
a
you,
hand
guys.
to Dr. Katsumoto.